So STEMI is the most important of them all, and here is a nice ECG that I found online, and I put the reference there, and you can see how striking some of the ECG changes can be. I showed you earlier a bunch of ECGs that are less obvious, but they can be quite striking, and with a clinical picture you can call up your interventionist and tell them, let's cath this patient right away, because it's time is muscle, and we have a door to needle. Needle means when you first puncture the skin for a cardiac cath. That's a key performance indicator. So when you call your interventionists and the interventional team and you bring them from home, and you should have started your procedure optimally within half an hour of the patient being in the emergency room and diagnosed. We call that activating the STEMI code. So when to activate a STEMI code? You activate it if the patient has chest pain consistent with acute myocardial infarction and ECG shows definite evidence of ST elevation with 1 or more millimeters of ST elevation in 2 contiguous leads. That's 2 small squares or 1 small square in the limb leads. And new LBBB, again, those are 3 Bs, left bundle branch block. And the patient does not have any of the following conditions. Okay, of course, these are all as long as there's no contraindications. So the following conditions must not be met in any of the patients. Presentation of finding that makes STEMI diagnosis uncertain, such as pericarditis. Age above 80 years, because it makes the risk much higher for mortality. Onset of pain more than 12 hours prior to presentation, because that means probably the muscle's already dead. You're better off going through a more conservative management and then do an early approach later on. Resuscitated cardiac arrest with uncertain diagnosis. Someone came with cardiac arrest, you don't know the cause, they resuscitated him, and then they found ST elevations and troponins. That's probably due to the compression of the chest and the breakage of the ribs and the contusion and the pressure that was put on the heart itself. Not to mention the period of hypoxia within which the heart was, because there was no actual proper perfusion. It was only through CPR. Known to be DNR, you never perform an invasive procedure on a do not resuscitate status. Someone with a major trauma, again, because the risk of contusions and type 2 MI. Severe comorbidities, including renal failure within those parameters, more than 176 micromole per liter creatinine, or severe COPD, with someone who's on home oxygen, dementia, because that probably confounds your diagnosis, dementia, severe disorientation, ability to cooperate or provide consent, and also that means the functional status and the expected outcome of the patient, and severe bleeding disorder. In those cases, involve someone more senior, and you want to make sure that you're following the best ethical standard. Before saying a code STEMI is deactivated, you want to discuss it with your interventional cardiologist. So you found that you have one of the confounders, you call your interventionist, okay, tell them, so I have a patient who has an ST elevation, but they have one of the reasons why we should deactivate a cath lab, as mentioned before, and knowing that time is muscle, shall we proceed or no? And they can tell yes or no, and then you can go ahead and give them the anti-ischemic protocol and medications and all the supportive care and conjunctive care possible. So remember, there is a concept of door to needle. Remember, teamwork in STEMI codes. Someone needs to be calling and activating the cath lab team. You need to be calling your interventionist. Someone needs to be establishing cannula. You need to give your orders clearly. You need to communicate with each other properly. Someone should be doing an ECG. Another person should be drawing bloods, etc. And all of those decisions are done even before you do bloods. The only thing you've done is in the triage, patient comes in with chest pain, you immediately do an ECG. And that clarifies the order in which you do things. So you should know, in an emergency room, anyone who comes with chest pain, the first thing you do is an electrocardiograph, because that's how you're going to rush the patient to cath lab and take extreme measures or not. And basically, we perform a transcutaneous puncture and we push a guiding wire to the root of the aorta where you have your coronary cusps. That's where you have the right and left coronaries coming out. And then over the guide wire, we put a guiding catheter. We put a catheter, a diagnostic catheter, with a hollow lumen, and we inject a contrast in it once we have engaged the left coronary and we see it, and then we disengage and then we engage the right coronary. Sometimes you need to take your cath out, put another one to engage either or, and that way we can localize. You see here, we were able to localize our pathology to the right coronary artery and the proximal segment, and we also can quantify the degree of stenosis. And once we do, we put a guiding catheter, and in it we put a small guiding wire that goes intracoronary, and then over that we slide our balloon stent. Sometimes we balloon then stent, sometimes we stent right away, sometimes we balloon then stent, and then we balloon again for what's called a post-dilatation to make sure that the stent is properly in place. All right. So that gives you an idea of what cardiac cath is. So treatment depends on the diagnosis amongst the spectrum, which is STEMI, unSTEMI, unstable angina. There is a simplified approach. Now, once you triage your patient and you know in the spectrum where they are, you call your interventionist, or there's no need for emergency cath. Sometimes we take a patient to the emergency cath right away. Just due to continuous or evolving active angina, even without an ST elevation MI. So that means that it is a dynamic issue. So whenever you're in doubt and you think someone is severely ill, there's no harm in calling the interventionist. Some of the tools we can use is an ECG every 15 to 30 minutes. Remember, the case that we've done before had a Q20-minute ECG order. And you can also do serial troponins. A rise or fall means that something is going on, and that alludes to myocardial pathology. If investigations remain normal, search for an explanation, so an alternate diagnosis, such as pulmonary embolism, for example. And if intermediate risk, you can stress the patient. An exercise stress test, an ECG stress test, an echo stress test, or a chemical stress test can be used. If high risk, stress test urgently, or even proceed to a diagnostic angio. Patient symptoms are perfectly typical and they already have all the risk factors. You can take them to a cardiac angio, and that is perfectly acceptable as long as you get an informed consent. So a concept advice, meanwhile, with any patient, load them on dual antiplatelets, and if in doubt, for all patients, you do it for all high-risk patients and for all patients if in doubt. Any person, in doubt means any person you suspect has an actual MI, load them with dual antiplatelets and anticoagulate them unless literally there is a contraindication to that. If you're going to take patient to cath, ask your interventionist for their preference on antiplatelet, because there's a range of them and they work with different acuities and they have different half-lives, and there are multiple evidence on their use. The most common of which are aspirin and clopidogrel. So antiplatelet is primary hemostasis. Anticoagulation is secondary hemostasis. We are stopping the acute thrombosis if there is any thrombosis at all. That's going to improve our coronary perfusion. Okay, every patient with suspected acute ischemia, we're going to start them on some anti-ischemic medications, and we're going to pain control, and we're going to give them supportive care. So if they're hypoxic, give them oxygen. And these medications include nitrates, blood beta blockers, calcium channel blockers, and morphine. So why nitrates, beta blocker, calcium channel blockers? Because they're going to dilate, they're going to slow the heart down, and morphine is also going to decrease the systemic demand for oxygen as well as treat any pain. And remember, chest pain is pretty bad. Anginal pain is pretty bad. It's a very bad pain. So that's going to improve your perfusion. It's going to improve your coronary perfusion. All patients with acute ischemia must receive the following unless contraindicated. So This slide is going to introduce you to how we reference landmark studies in internal medicine, all of the specialties, and especially in cardiology. We like to reference our landmark studies for our different clinical decisions, and that shows you how research is translated into clinical practice. So according to the Prove It TIMI 22 study in 2004, we use high-intensity statin. It's going to decrease ischemic stress and decrease percutaneous coronary intervention myocardial infarction. And that's why we use things like atorvastatin 80 or rosuvastatin 40 milligram, and we load the patient's stat along with their antiplatelets. It's going to improve their outcome. Ezetimibe is another anti-lipid agent, and although not always added by most clinicians, there's good evidence that it probably should be, as per the Improve It trial in 2015. And ACE inhibitors and ARBs should be used in all patients who are hemodynamically stable and their renal function is stable, because if you have hypoperfusion, you're going to damage the kidney, and if the kidney is already damaged, you're going to damage it more. So those are the only reasons you avoid them, or if someone is truly hyperkalemic. But otherwise, they have good evidence. And the good evidence is especially true if the ejection fraction is below 40%. Okay, so this is also going to improve your coronary perfusion. Other early adjunct therapies include intra-aortic balloon pumps. So we put a balloon that expands every time there's diastole. Because remember, in systole, the aortic valve, let's try to write that. The aortic valve opens here. The aortic valve opens in this area, and that pushes the blood out. And then in diastole, blood kind of falls, the valve closes, and whatever blood is here falls down. So that improves coronary perfusion. So coronary perfusion is a diastolic perfusion. So if I put a balloon pump that inflates with each diastole and deflates with systole, of course, it depends. You can have some air in the balloon. And if blood is coming out at higher pressure, then it's going to deflate it. And the deflation-inflation is also controlled by a machine that's hooked at the other end of the catheter. The catheter is usually inserted in the femoral area, in the femoral artery. And so that improves your coronary perfusion. So, and especially used if you cannot have a definitive PCI, definitive intervention, even if you did an angio. In STEMI patients, you need a reperfusion strategy. So primary PCI is the one we discussed, the one we showed you, but what if I'm in a center that does not have a cath lab, or I don't have an interventionist, or for whatever reason I cannot do PCI? Then you consider fibrinolysis, things like alteplase or retiplase, medications that destroy tertiary hemostasis. A thrombus is there, it's trying to reorganize and make itself settle, and you break it down. The reason this is dangerous is because if there's any bleeding risk anywhere in the body that is being controlled by tertiary hemostasis by a physiologic thrombosis, I don't know if physiologic is the right term to use here, it could potentially cause severe bleeds, could potentially cause brain bleed. Someone who has any open injury is also at risk. So there's a balancing act that you need to do with fibrinolysis because it has a potential to mortality. And so while for all internal medicine residents and cardiology fellows, you need to know the absolute and the relative contraindications and the approach to all the relative contraindications, here I'm just going to present to you the absolute contraindications for fibrinolytic use in ST elevation myocardial infarctions, which include the following: prior intracranial hemorrhage, known structural cerebral vascular lesion that could potentially hemorrhage, known malignant intracranial neoplasm, again, that could potentially hemorrhage because neoplasms are usually highly vascular with new proliferation, meaning neovascularization, and ischemic stroke that can have a hemorrhagic transformation, suspected aortic dissection that can increase or bleed, active bleeding or bleeding diathesis anywhere. That excludes menses because that's physiologic. Significant closed head trauma or facial trauma that can cause internal bleed within all the last 3 months. Intracranial or intraspinal surgery within the last 2 months because that can also cause bleed in that area. Severe uncomplicated hypertension, unresponsive to emergency therapy. Usually that happens in the emergent state. So someone is having STEMI and has the medical emergency of hypertensive emergency, then you also will avoid fibrinolysis, because that means there's high pressure. So if there is any risk of bleeding that is obscure to you as the clinician, the hypertension is going to make that risk much higher. And for streptokinase use, prior treatment within the previous 6 months means that it is absolutely contraindicated, because streptokinase is immunogenic. It causes you to develop antibodies against it. We usually then admit the patient and observe for a few days for post-MI complications in the acute setting, and assessment of myocardial residual functions with imaging modality. Usually we do a formal echo if it was not already done, and we repeat it post-intervention to see what happens. And we try to optimize the medical therapy, treat any acute kidney injury if there is any, and any complications thereof. And sometimes there is precipitant to an MI, so an increased stress state for whatever reason. We also try to treat that. And we try to look for, the reason I have all of those is to try to kind of introduce you to post-MI treatment. So we also try to look for complications. The immediate would be heart block, RV infarct, needing optimized preload like we discussed with volume resuscitation. And then mechanical complication can happen even after the definitive treatment and reperfusion strategies, including cath. So you can have free wall rupture, a ventricular septal defect that is related to rupturing of the septum, because of the ischemia and the brittling of the muscle and the acute inflammatory process, papillary muscle rupture for the same reason, other arrhythmias, all of them can happen really, LV thrombus, ventricular aneurysm, pericarditis, and Dressler syndrome, which is immunogenic pericarditis. Finally, you should know that an actual plan for long-term management must be established. So here's something that we do for all patients. We actually have physical checklists that we need to meet for our patients. So we try to know exactly what is the risk of having an MI again over 6 months. We try to intensify all of their medications to the maximum doses possible as per guideline. We try to make sure that all of them are on dual antiplatelets for the right amount of right duration and the right dose. For example, anyone who had a stent should be on it for at least 1 year. We try to make sure any patient who tolerates beta blocker should be on it with a target heart rate that is at the lower physiologic limit. We want to have tight control of their LDL cholesterol to prevent further stenosis and accumulation of atherosclerotic plaque. We try to give aldosterone antagonists because the renin-angiotensin-aldosterone axis is the axis that is most validated clinically to have significant improvement on mortality and even morbidity. We give nitrates for whoever is in need for nitrates for symptomatic relief especially, and oral anticoagulation for anyone who developed atrial fibrillation or has an LV thrombus, because LV thrombus can happen when you have an infarct that affected the apex of the heart and it's not moving well, so you get thrombosis because you lose the laminar flow of the blood and the rapidity of the flow. So you have enough stagnation, stasis to cause thrombosis. But that is not the end of the list. The list actually goes on. So for patients who have severe LV dysfunction, we need to follow them up in 6 months and then see if they qualify for an ICD, an implantable cardiac defibrillator, for example, especially if they have risk of VT or VF or have had documented episodes, or there's a first degree relative with sudden cardiac death, or so on and so forth. So ICD placement or consideration thereof from an electrophysiologic perspective, that an ICD is an implantable cardiac device with someone having a battery under their skin and wires in the heart. And that is all good and well. The most important thing we do in the checklist is the non-pharmacologic therapy. It's the counseling, it's the smoking cessation, it's the lifestyle modification, it's the dietary modification. Thank you very much, and I hope you found this presentation useful.